I see more folks entering the webinar. We'll take just another minute or two to allow more folks to join, and then we'll go ahead and get started with this month's Voices of AAPI Communities webinar. Perfect. Why don't we go ahead and get started? I'm sure more folks will probably continue to join in and jump onto the webinar. Welcome everyone to this month's Voices of AAPI Community Briefing. My name is Sarah Sadwani. I'm a senior researcher with AAPI Data, as well as a political science professor at Pomona College. We're coming to you today with critical insights on timely policy issues impacting our nation. We have a lot of primary elections going on across the nation, and more to come as well. So there couldn't be a better time to be talking about some of the most important issues impacting Asian Americans and Pacific Islanders. I'd, of course, like to thank our partners, AAPI Data, APIAVote, Asian American Journalists Association, and NCAPA for today's briefing, as well as the Associated Press and NORC for their ongoing partnership. The Voices of AAPI briefings are an incredibly important resource of data and insights for our communities regarding timely policy and social issues. And this month is taking on some of the core issues of mental health, discrimination, and hate. We've covered a whole lot of issues in our briefings, as no doubt if you are a regular guest to our webinars, no doubt you know. I'm thrilled to be welcoming our speakers today, which we'll hear from a little later. But first, I want to turn to and welcome Karthik Ramakrishnan, our founder and executive director of AAPI Data. He's going to take us through the main findings of the survey. Karthik, over to you.
Thank you, Sarah. And hi, everyone. We're excited to share these results with you and also to hear perspectives from key partners, including those that are part of NCAPA, which is the National Council of Asian Pacific Americans. Let's go to the next slide. So this is the report you'll see on our website. If you just go to apidata.com/surveys, you'll see our surveys in reverse chronological order, and this is our latest survey report. You'll also see updated findings. We have a resource guide called Voices of Community. We have plenty of other resource guides as well. And what these resource guides do is to help people make sense of all of the data that we have on our website. It's a lot, but we highlight some key ones by theme and by population. Let's go to the next slide. So what do we find in our latest survey? So first, this is built on the Amplify AAPI panel, and this is the first national probabilistic panel of Asian Americans and Pacific Islanders with in-language support. Next slide. So what are some of the major findings? One, so we have some findings on health, mental health, and then discrimination and hate. So when it comes to health, API adults report the most confidence in doctors and nurses, as well as scientists and medical researchers, to do what is best for public health. Only 44% say the same when it comes to the federal government. Why does this matter? This shows ongoing low confidence in the federal government on health policy, and it's also reflected in high disapproval ratings of HHS Secretary Robert F. Kennedy that we found in June of 2025, as well as more recently in February of 2026. When it comes to trusting others to do what is right for them and their families, so it's a little bit different here. It's not about confidence in what is best for public health, but trusting others to do what is right for them and their families. Again, API adults give high marks to doctors and nurses and pharmacists. They give very low marks for hospital executives, health insurance providers, and public health officials in the federal government. State health officials do better, as do mental health counselors. But note that with mental health counselors, it's nowhere near what it is for doctors and nurses and pharmacists. So this is something to pay attention to as we think about trusted messengers, trusted providers, as well as where some of the pain points are when it comes to health policy and health delivery. Next slide. We also find that immigration is creating a very strong chilling effect. 1/3 are extremely concerned or very concerned about medical records being shared with immigration enforcement, and 21% are somewhat concerned. And we know that this is a major issue, and I hope we'll be able to hear from Jeff on this later in terms of what this looks like on the ground. We also find that most, so close to 80%, have used alternative medicine to treat or prevent a health issue in the last year, and about half cite a recommendation or prescription by a medical doctor, friends, or social media as what led them to seek that alternative treatment. Next slide. So when it comes to hate crimes and hate incidents, if you put them together as hate acts, we see that more than 1 in 4 APIs experienced a hate act, with hate incidents 23% more common than hate crimes. So this is lower than it was at the peak of the pandemic, but you still have an estimated 2 million Asian American and Pacific Islander adults that are experiencing violence or threats of violence because of their race and ethnicity. That's what the numbers show. Finally, about 3 in 5 APIs think that it's somewhat likely that they will be discriminated against because of their race and ethnicity in the next 5 years. And 47% say they think that it's going to be at least somewhat likely because of their immigrant background or status. So let's go to the findings in more detail. So we'll take a deep dive on healthcare. By the way, you can find these results on our website as well. So bottom line, API adults trust their doctors, but not the federal government. Now, it's this particular federal government and the way that they're implementing healthcare policy is what we can say, because we didn't ask about the difference between federal government and state government in prior administrations. Paying for healthcare is the top source of anxiety when it comes to people's health issues. And they're worried about not being able to afford the treatments they need. And this worry cuts across party lines, age groups, and detailed origins. Finally, immigration enforcement is a significant area of concern and worry. And it's not just those that are recently arrived where this is a source of concern. Let's go to the next slide. So this is what the numbers look like, right? It's kind of like night and day. Our communities trust doctors and nurses and scientists and medical researchers. Not as much trust. I mean, if you think of somewhat confident as trust, I suppose alternative medical practitioners are up there, and certainly very low confidence in the federal government. Next slide. Now, there are important differences, and you can see the disaggregated results on our website, and you can download them and peruse those tables at your leisure. We see somewhat higher confidence among Vietnamese Americans and Asian Indians and Filipinos, very low confidence among Japanese Americans. Next slide. When it comes to confidence, so the same thing about confidence in the federal government to protect public health, we see much lower confidence among those 18 to 34 and among women and among Democrats. Next slide. So in terms of the second question, not in terms of acting in the name of good public health, but trusting different actors to do right by patients and families, we see that doctors and nurses and pharmacists and mental health counselors are at the top, but with doctors and nurses being at the very top, along with pharmacists. At the low end of the spectrum, we see health insurance providers and hospital executives. If you look in the middle, we see a significant difference between trust in public health officials in your state department, as opposed to, I mean, state government, as opposed to public health officials in the federal government. Let's go to the next slide. We also asked about use of alternative care to treat or prevent health problems. The font is a little bit small there, but what we see at the top of the list, you might think acupuncture is at the top of the list. No, it's dietary supplements such as vitamins, melatonin, or fish oil, and then probiotics, including in pills, yogurt, kimchi, or some teas. We also see a significant proportion of our population engaging in mindfulness-based stress reduction techniques, such as meditation or mindful breathing, followed by movement practices and various other treatments. Importantly, you have 20% uh, of the population that says, I've not used any of these to address a health problem in the last year. Next slide. Now, when you tally them all up and say any type of alternative care, are there differences? There are some differences that we notice by ethnicity, with Korean, Filipino, and Japanese Americans among those most likely to say so, and Vietnamese Americans among those least likely to say so. But it's still all well above 50% if you count any one of those treatments or techniques. Next slide. Not a huge set of differences when it comes to age or even partisanship, but there are some noticeable differences by gender, where women are significantly more likely than men to say that they have used the one or more of these alternative treatments. Next slide. Next, we ask about various concerns about healthcare. Affordability is at the top of the list, not being able to afford the treatment options that you want, followed by your treatment options not being taken seriously by your providers or insurance. We also see significant concern about medical records being shared with immigration enforcement, and concern about language service access is less prevalent in this among survey respondents than these other concerns. Next slide. When it comes to affordability, we see the most elevated concerns among Vietnamese Americans. There are no statistically significant differences between Pacific Islanders and Asian Americans on this measure. And I mean, it's still elevated, right? If you look at Korean Americans, 45% say they're extremely concerned or very concerned. But when we look at across detailed origin groups, Korean Americans are less likely than Vietnamese Americans to cite healthcare affordability as an extreme concern or strong concern. Next slide. When it comes to gender, we don't see much of a difference there. When it comes to age, those age 65 plus don't show as much of a concern, and that is likely because of Medicare addressing some of those affordability issues in ways that it doesn't among those in younger age populations. Importantly, we don't see too much in the way of partisan differences about concern about affording healthcare treatment options. Next slide. Terms of concern about medical records being shared with immigration enforcement. No, what's interesting is the ethnicity patterns don't always stay the same. And we see significant concern among Asian Indians and Vietnamese. What was surprising to me was also to see significant concerns among Native Hawaiians and Pacific Islanders in the survey. Um, there are sizable proportions, although not as high, proportions of foreign-born or immigrant populations among Pacific Islanders, and it's concerning to see that this is a high level of concern about medical records being shared with immigration enforcement, potentially hinting at racial profiling, regardless of immigration status, as an area of concern. Next slide. We also asked about why people used alternative care to treat or prevent health problems. And the most prevalent reason, this surprised me, but this is not my area of expertise, and we have many others who can speak to this, was that it was recommended or prescribed by a medical doctor, right? So it's not necessarily opposed, right, in terms of alternative treatments and more, say, traditional or Western medical treatments to address various issues. We also saw a significant number of respondents saying that conventional medical treatments were too expensive. We also saw that peer effects play a significant role here. If you add the 15 and 35, you get 50% saying that it was either a minor reason or a major reason that it was recommended through friends or through social media. Next slide. We also asked questions about stress and anxiety, and some of the results surprised us. So stress, that part wasn't as surprising, although we might have thought that racial discrimination might have been the most significant source of stress, but it's finances. It's financial concerns that are the most likely to cause stress and anxiety in our community. When it comes to anxiety, we see that it's widespread, especially among the young, and the levels are about the same as we saw in last year when we asked the same set of questions. Next slide. So when it comes to sources of stress, we see personal finances at the top, followed closely by health concerns. Relationships with family and friends were also a significant source of stress, followed by discrimination. Next slide. When it comes to personal finances as a source of stress, we see a pattern that was similar to what we saw about healthcare affordability, where this is less of a concern among those age 65 and over as it is among those in younger age groups in our population. But you see this level of stress across the board, including across party lines. Next slide. In terms of health concerns as a source of stress, we see women slightly more likely than men to say that health concerns are a major or minor source of stress. And you see health concerns as a source of stress that increases by age. Again, no major difference across party lines when it comes to health concerns as a source of stress. Next slide. Now, we use this GAD-7 scale of anxiety, so it's 7 items. We are able to disaggregate them. And the way the scale works is you add it all up and you come up with different tiers of levels of anxiety. So I'm not going to dwell too much on this, and you can read more in the survey report that we did with Associated Press and NORC. Next slide. So in terms of severe anxiety versus moderate to mild to minimal anxiety, we see that Asian Americans and Pacific Islanders are about the same, although the severe anxiety does seem to be higher among Pacific Islanders, but I would just caution, given the survey's margin of error, especially for the smaller NHPI population, to treat that with a bit of caution. When you add the severe and moderate anxiety, we see that Filipinos tend to have among the highest levels of anxiety among Asian Americans. Japanese Americans, by contrast, have among the lowest. Next slide. If we look across age, gender, and party ID, we see heightened anxiety among those in younger age groups than among those in older age groups, and no significant difference across party ID when it comes to severe or moderate anxiety. Next slide. Finally, when it comes to discrimination and hate, let's go to the next slide. So our summary findings here, most API adults anticipate future discrimination. So about 60% believe that it's at least somewhat likely that they will face race-based discrimination in the next 5 years. And roughly half identified discrimination as at least a minor ongoing stress in their daily lives. So it's putting those two pieces together. When it comes to hate crimes or hate incidents, 11% report a hate crime in the last year, and 23% report a hate incident. When it comes to either of those two, it ends up being 28%. When it comes to discrimination, discrimination on the job is the most serious area of concern and experience where people have experienced it. And hate crime rates vary significantly by ethnicity and also by gender. What we find here is what we found in prior surveys by us, as well as the California Health Interview Survey and others, that men are actually more likely than women to have experienced violence or threats of violence related to one's race or ethnicity. So let's go to the next slide. So we were able to break down the types of hate incidents, both in terms of crimes as they're defined by the Department of Justice, as well as hate incidents that don't rise to the level of violence or threats of violence or damage to property. Let's go to the next slide. When it comes to racial discrimination, as I'd mentioned before, we found it most frequent when applying for jobs and more generally in your community, followed by dealing with police, and then finally when getting healthcare from doctors and hospitals. So it all depends on whether one considers that to be a big deal or not as big a deal. But 18% say, since health is our theme today, that they've either experienced it often or sometimes. When it comes to anticipated discrimination, we see that race-based discrimination is the highest in terms of on what basis people expect to face discrimination in the next 5 years, followed by immigrant background or immigration status, gender, and religion. Next slide. When it comes to racial and ethnic discrimination when applying for jobs, we see anticipated discrimination across the board. No big differences when it comes by race or by ethnicity among our communities. Next slide. When it comes to anticipated discrimination when getting healthcare, again, we don't see major differences by ethnicity. We do see a significantly higher concerns among Pacific Islanders, thinking that they will often face discrimination when getting access to healthcare in the next 5 years. Next slide. Oh, actually, sorry. On that side, so let's just go back to the prior slide. Sorry, this is not about in the next 5 years. In each of the following situations, how often would you say you personally have been discriminated against? So you see much higher reports among Pacific Islanders reporting experiences of discrimination when getting healthcare. So with that, I'll turn it back to Sarah and the rest of our panel.
Great. Thanks so much, Karthik. There's always so much fascinating information. I love that this month we're taking that deep dive into health, mental health, some of the issues that we know are so incredibly important across all of our communities and yet often aren't always discussed. I want to turn now. We have an incredible panel of speakers to join us in a discussion about this data. Jeffrey Caballero, Crystal Canare, Pata Suyamoto, Joanne Panio. Some of you have joined us in the past, others have not. So when we start off our conversation, I'll ask you to just say a few words about the organization that you're from and some of the work that you do. But I want to start with you, Joanne, and really think about sort of the top line pieces around healthcare affordability and fear. And actually, before I do, let me, as a reminder for those of you joining us, to please use the Q&A section on Zoom to drop your questions in there. We'll be in a discussion, but I definitely I'll be keeping an eye on that tab to make sure your questions are also answered. But Joanne, let's start with you, coming, of course, from NCAPA. About half of AAPI adults are extremely or very concerned about not being able to afford healthcare treatment. This is true, actually, even for many non-AAPIs as well. But we also found that about 1 in 3 worry about their medical records being shared with immigration enforcement. From a policy advocacy standpoint, what systemic changes do you feel like are needed to address some of these structural concerns, especially in particular, right, for the non-English speakers who showed heightened concern regarding immigration enforcement? We have seen the role that immigration enforcement has been playing out on our streets. So really combining some of these topics and threads, I'm curious to hear your thoughts from the NCAPA perspective about the advocacy that needs to be done in this area.
Thanks so much, Sarah. Always great to see you. And thanks to Karthik and the API Data team for today's webinar. Not surprised at all that folks are feeling the stress and anxiety when it comes to being able to afford healthcare related treatments when the prices of everyday items continue to go up. And folks are forced to choose between, am I going to pay for this doctor's bill or am I going to make rent this month? Pay for the utility bills, groceries, childcare. And when it comes to the ongoing concerns over immigration enforcement, given what we've witnessed nationally and what folks may be experiencing and working on locally, these are all real concerns. So The three things that I wanted to highlight for us today and would encourage folks to keep in mind when advocating for changes in response to the problematic systems and structures that are currently in place and that continue to make things harder for folks is one, ensuring language access, two, making sure that programs like Medicaid are funded and implemented, and then three, no more funding for immigration enforcement and instead more oversight. So first on the topic of ensuring language access for immigrant communities, including our NHPI communities, more broadly speaking, there are about 26 million people across the US who have limited English proficiency. That includes about a third of our own NHPI communities. And I think that it's interesting based on the data that nearly a quarter of our folks reported they're concerned about language access services, right? Following last year's executive order designating English as the official language of the United States, we know that the federal government has rolled back prior guidance that has been around for more than 25 years. For example, that includes removing guidance itself, the taking down of web pages, as well as pulling resources that have been available in multiple languages. So despite these changes, I think we need to make sure that healthcare systems and providers continue to offer that meaningful and equitable access to healthcare, such as by providing forms in languages other than English and making sure that interpreters are available to individuals and families. When it comes to language access, it's harder to go through the process of trying to obtain care. Trust is important when making decisions, and I think we saw that in the data too, pointing to an earlier finding that Karthik had pointed out with AAPI adults identifying a higher sense of trust in doctors and nurses and also pharmacists, right? When folks can understand in their own language what a diagnosis might be, what the prognosis is, and the availability of treatments, they can make a more informed decision about their own health or that of a loved one. So NCAPA recently worked with Congresswoman Chu on her bill, the Language Access Board Act, which does a number of great things. But one that I wanted to emphasize here, given the current climate, is that it would establish an independent board of community experts and federal agency officials to enforce language access guidance and regulations across agencies and departments, such as those in the healthcare space. So I think this is something that's needed given the rollbacks that we'd seen based on the executive order from last year. The second point on ensuring that programs that support individuals and families with low income like Medicaid continue to be funded and implemented. I know that API data has some great numbers from last year that pointed to that there are over 1.1 million Asian Americans and over 63,000 Native Hawaiians and Pacific Islanders who have no health insurance coverage. So when we keep this in mind and knowing what took place last year between the partial offset of the cost of trillions of dollars in tax cuts to fund Trump's tax bill that benefited the wealthy, this legislation included nearly $1 trillion in cuts to the Medicaid program itself. At the end of 2025, with the expiration of key ACA provisions, including the enhanced subsidies, this spurred this increased pressure on Medicaid by making marketplace coverage far more expensive, pushing people towards Medicaid at the same time when states were already managing coverage losses. I think this resulted in a higher churn, more uninsured people, and a greater strain on Medicaid enrollment overall. These challenges are felt and especially true for our NHPI communities, including COFA citizens, those who are from the Federated States of Micronesia, the Republic of the Marshall Islands, and the Republic of Palau, who don't ordinarily have access to Medicaid, even though they are eligible. So with Medicaid being restored for COFA citizens a few years back as a result of the renewed compact agreements between the US and COFA states, the implementation has been slow. And I'm sure there are folks here who know more than I do who can share more about that. But that coupled with the cuts that we saw to Medicaid, I think it's making it more and more difficult for folks who ordinarily would be eligible to access these benefits. The third and final thing I wanted to note was no more funding for immigration enforcement and instead increased oversight. We've said this on numerous webinars. ICE is already the highest law enforcement agency in the country. And we know that personal and sensitive data has been shared with ICE, including taxpayer information, work authorization data, voter data, and others, including Medicaid. So one thing that folks should be aware of and are likely following is that there is this party line bill that the president has said he wants on his desk by June. Just today, the Senate Budget Committee advanced what we expect in this bill will head towards the floor soon. And this bill is going through something called the reconciliation process, which essentially allows one party to move the bill forward without the other party's side. In other words, it's a way to get around the Senate filibuster when one party can ram their own interests without the usual checks and procedures. So wanted to note that in this bill, its way it's currently written, There's nearly $23 billion for Border Patrol and over $30 million for ICE, on top of the $75 billion that they already received from Trump's tax bill last year. We know that there have been pushes for requiring judicial warrants, so that point of oversight, and keeping federal agents away from the polls, which we know that this president has floated this idea around very loosely and has said a number of times that we might see agents at the polls later this year. And even immigration officials have said on the record when they've been asked whether their agents will be set in the polls, haven't given a definitive answer. So these are voted down. It's something that we're continuing to track, and we wanted to make sure that folks are also aware in terms of how fast this bill is moving forward. So on that note, when it comes to educating and informing policymakers about these three things, the importance of language access services, Medicaid provisions, as well as immigration enforcement, we encourage folks to share your stories, point to the local impacts, and let your elected officials know. Again, we can't tell folks what to say, who to say, or how to connect, but if folks have questions how to engage in this work, feel free to reach out to NCAPA and join our newsletter if you haven't already. And I'll go ahead and drop our link into the chat. Thanks, Sarah.
That's perfect, and just a lot of great points that you have raised there. I mean, I actually did not realize how quickly that enforcement bill was moving through Congress. I also really loved that first point that you made around having kind of community boards with doctors and nurses on it. Those are the trusted messengers, so it makes the most sense to identify ways to bring them closer into the conversation about how healthcare decisions are being made. I want to turn to you, Crystal. I can't wait to hear a little bit more about your organization. So I hope you can share a little bit about that. But I also want to talk a little bit about the economic and health stressors and some of the data that we looked at there. And we see that younger AAPI adults are experiencing higher rates of anxiety, are more likely to cite personal finances and health concerns as sources of that stress. I'm curious from your perspective, how can community networks build better resilience and support systems for these intersectionally vulnerable groups? I mean, the young people, most certainly, this is a generation of folks who have faced a considerable amount of financial anxieties. They're carrying multiple burdens. So I'm really curious to hear more about some of those community networks and how they can respond to these concerns that we're seeing.
Absolutely. And first off, thank you, Sarah, Karthik, Amanda, API Data team, for inviting me and NAPIMA to this important conversation. So a little bit about NAPIMA. We are the National Asian American Pacific Islander Mental Health Association, and we're dedicated to promoting and redefining the mental health and well-being of Asian American, Native Hawaiian, and Pacific Islander communities nationwide. We move the needle on NHPI mental health through our 4 areas of work. So we develop and offer culturally informed mental health trainings. We facilitate community mental health programs like our virtual Napian network of people with lived experience and our youth mental health leadership programs. We also inform national public policy and advocate for the mental health needs and increased resources for our communities. And last but certainly not least, we respond to and provide mental health referrals during times of crisis. So whether that's individual mental health crises to community crises, such as, for example, the horrific shooting this week at the Islamic Center of San Diego. And so at NAPIMA, we acknowledge that all of this takes a whole health, public health approach to supporting the mental health of our communities. It takes work across all of our systems and industries, much like those that have brought together this webinar. It takes not only those that are, professionals in the mental health field, but it involves centering those with lived experience. And it involves combating the hate and violence that we're experiencing with opportunities for connection and belonging. And a lot of the things that we do at NAPIMA involve this recognition of more culturally relevant models of thinking. So whether it's knowing that our body, mind, and spirit are connected, or honoring the cultural ways of healing that are rooted in our connection to our ancestors, our lineages, and our land. And so that's a little bit about NAPIMA. And to your question, all the things that are happening in this world today, they are being compounded. And, these mental health challenges, they worsen in isolation. So yes, it is so important, especially as NHPI cultures are more collectivistic cultures. It's so paramount that we meet people where they're at. We, provide them the tangible things that they may need, and we surround these individuals with the resources and supports that they may need during a time they're carrying these multiple burdens. I'd also like to note that, the statistics around NHPI mental health have remained consistent over the years. And what those statistics look like are that NHPIs are still the least likely out of all racial groups to seek mental health services. And in more recent years, suicide is the leading cause of death in our NHPI young people. And so when we talk about these community networks, how do we build resilience? How do we build these support systems? It's going to take all of us to turn the tide on suicide and to be able to make mental health and well-being a priority, number one priority for our communities. Again, not just these health-related organizations, not just the certified clinical mental health service specialists and systems, but everyone. And so that involves, improving the behavioral health systems that be and figuring out how to keep the doors open for a lot of these organizations that are navigating this funding landscape. But also it really does take, all of us to break that stigma about talking about mental health with our loved ones and peers. As we talk about us relying and trusting our medical professionals, we also know that when it comes to mental health supports, we know that our peers I remember a survey saying like our moms are the ones that people turn to be those first responders and trusted members. And so I would just say, like, do we as community members know what to say when someone's going through a mental health challenge? If not, I encourage folks to take a training with NCAPA. And we also offer organizational trainings too for whole staffs. Do we as community members have spaces or activities we go to or could refer other people to support your mental health and well-being? I encourage folks to take part in NCAPA's virtual or in-person mental health trainings, as well as the many trainings and spaces that are being offered by our community partners. It's so important that we make our wellness practices as routine as going to the gym or the workplace, And I'll end on this. As an example, last Sunday, we kicked off our Rooted in Resource series here in Denver and Colorado. And it's a wellness space for our NHPI community leaders. We do so much for our communities. And so we took that opportunity for us, dedicate ourselves to rest and providing mutual aid resources. So whether that was free groceries and produce, health screenings, movement practices, connecting folks to various therapies, yogas, sound healing, Reiki, it was a space for us to really just be in community with one another. And so when we talk about building resilience and support systems, it's so important to find the harmony between, doing work for the community and the space we can just be in community to cultivate those relationships and nourish our collective well-being. So just a few thoughts there. And again, thank you for having us.
Yeah, perfect. No, thank you so much for sharing all of that. And I actually would love to take one of the NCAPA trainings as a mom, as a professor. I feel like I do often have people turning to me. So I'm so glad to hear about that resource, as well as the incredible work that y'all are doing. Jeffrey Caballero, I want to bring you into this conversation. Of course, I want you to share a little bit about the work that you're doing at APCHO, but I also want to talk a little bit about some of this data that we're seeing around trust in doctors, as well as high rates of discrimination, because that data presents a bit of a paradox, right? We found that 80% of AAPI adults trust doctors and nurses to do what's right for them, but at the same time, about 51%, about half of those folks, report having personally experienced discrimination when receiving healthcare from doctors. So I'm curious also just how you're thinking about this, how you reconcile this high trust in these medical professionals while at the same time reporting high rates of discrimination, and what some of the steps might be needed to make these clinical settings a little bit safer. Jeffrey?
Thank you, Sarah. I also just wanted to extend my appreciation to Karthik and API Data for the invitation to participate in this panel. To understand APCHO, the Association of Asian Pacific Community Health Organizations, you must understand what community health centers are. Community health centers, or FQHCs, is a 60-year-old federal program that is a critical part of our healthcare system in the United States and our safety net. The health centers serve 52 million people. That's 1 in 7 Americans across this country and the Pacific. And that includes 1.4 million Asian Americans, Native Hawaiians, and Pacific Islanders. APCHO's membership is a subset of this FQHC national network, as well as community-based organizations that serve AA and HPIs that are in poverty, medically underinsured, or uninsured in the US and in the Pacific Basin. It's important to note that APCHO member centers serve as the primary care home and safety net in our communities. What that means is that they provide access to anybody, regardless of ability to pay. But they do provide targeted language and culturally appropriate providers and services to ensure that our communities feel comfortable in the healthcare settings where they receive their care. So let me get to the paradox. And I looked at this from several approaches, and I have to admit, I really can't explain the paradox, and I'm not going to try because that's not my area of expertise, explaining paradoxes like this. But I will acknowledge and recognize that I think I come from a family, particularly a Filipino family, of physicians, nurses, and pharmacists, and I think many Asian Americans and Pacific Islander groups are similar in terms of how they have high respect for the healthcare field is highly regarded and is recognized for prioritizing patient welfare and public health. But I do want to make a point around healthcare discrimination, particularly. Well, let me back up. I don't want to talk about the different types of healthcare discrimination. The point I want to make, though, is that doctors and nurses are human, and our healthcare system, we know, is broken. That's why we have plans that relied on expanding civil rights enforcements, managing demographic data tracking, and integrating implicit bias training into our medical education. However, the current anti-DEI and anti-diversity climate has presented significant challenges for providers to continue these efforts to eliminate discrimination. So the question for me is, will these numbers experiencing discrimination increase? And what effects will that have on the trust on our providers and our community institutions? But let me close, though, with a point that I want to send to our providers out there. Healthcare providers can continue to work towards creating a more equitable healthcare system that serves all individuals effectively. We need to focus on regulatory compliance, promoting inclusive practices, advocating for policy change, and continuing to leverage the data that we've been collecting for our communities to advocate for them. You're not alone. Thank you.
Thank you so much for that, Jeffrey, and absolutely important words for everyone to hear. Pata, we have so many incredible guests joining us today. Pata, I haven't forgotten about you. Would love to bring you into this conversation to think a little bit more about those everyday stressors and coping mechanisms that we've been talking about. So, before we go into that, if you can say a little bit more about your organization and what it focuses on with respect to community health. But then more broadly, I'm kind of curious about the personal finances piece that we were looking at in this data, and health concerns, in which many were saying some of the top sources of stress for AAPI adults were personal finances and those health concerns. Additionally, 55% of AAPI adults have used non-dietary alternative approaches, including mindfulness-based stress reduction, which we found was about 32%. And I'm curious your thoughts on how we can better integrate these culturally utilized mindfulness and movement practices into the mainstream mental health support systems that folks have. So, Pata, if you can start us off telling us a little bit about your organization, and then move into thinking about that data.
Sure. The National Asian American Pacific Islander Empowerment Network, or NAPIAN, is actually it's a program of NAPIMA's, but it's a network of people who have lived experience with mental health concerns, either as individuals or as impacted family or friends. We work to support each other in a world that marginalizes AA, NHPIs, and those of us with mental health challenges. We share our unique experiences, knowledge, perspectives to inform mental health awareness, practices, and policy as we aim to tear down stigma and stereotypes and work toward liberation within our communities and beyond. So we have programming, we have monthly listening circles, which happen on the second Tuesday of the month, which are a theme. We might talk about eating disorders, for instance, and have a guest speaker come and talk about that. We have community building sessions on the third Thursday of the month, which are more informal. Special events. We just had a community documentary night. We partnered with a fellow named Adam Hicks and looked at No Crying at the Dinner Table, which is a short documentary about a family discussing grief and suicide in the AA community. We have book talks, open mics. We also have training opportunities. We have our Achieving Whole Health training, which trains wellness coaches and talks about body, mind, spirit as an approach, as Crystal mentioned. And we have our Growing Our Own, which is for people working in mental health fields that provides a cultural framework. In terms of, personal finances and health concerns, I think, the personal finances, everything's going up, and we know that that's a very, I think across the board, it's a stressor for people. But I wanted to spend a little more time on the mindfulness and the alternative approaches. So mindfulness is already somewhat incorporated into mainstream practices, which might account for that recommendation from doctors and practitioners that we saw in the data. So John Kabat-Zinn, some of you may have heard of him. He has a mindfulness center, stress reduction and mindfulness center at the University of Massachusetts Medical School. The dialectical behavioral therapy, or DBT, by Marsha Linehan. Mindfulness is a pillar of that modality. And Leahy Clinic offers acupuncture, which is a cancer clinic in Massachusetts, offers Reiki, acupuncture, and yoga as part of their treatment options. So we have some representation in already. But unfortunately, many times these traditional practices are appropriated without cultural humility, without cultural context, without attribution to the culture from which these practices come from. And I think that's really important, that we see, that a lot of these practices, have been sort of co-opted, and that bothers me deeply, actually. We need to promote a whole health approach, integrated health, body, mind, spirit, and I think as Crystal mentioned, we need to do things to fight stigma, because I'm disturbed by that sort of lower confidence in mental health practitioners. And I think some of it has to do with stigma around mental health concerns. And the fact that we are least likely to, get help until things are very dire. And I think that's something we need to pay attention to as a community, and to be able to talk about mental health. We need to educate practitioners, mainstream practitioners, in the efficacy of these alternative modalities. We need to make sure that people know, what they're about, what they do, and how they help people. And we need to educate consumers too. We need to educate our community, because they can advocate with their practitioners. They can advocate with health insurance companies. They can advocate in legislatures. Part of the issue in terms of affordability is that these practices are usually not covered by insurance. And so, they are add-ons. They may be less, we saw that they're oftentimes less money than a medical procedure, but if you're doing both, right, it adds up. So we need to, advocate for these practices to be billable by insurance. And we need to encourage community-based organizations to include these alternative modalities, in their work, and think about putting, I think, mental health and health-related things in places that they're not just for health, if that makes sense. Like if you're a civic organization, how are you promoting the mental health of people who you're, working with? So, and I also think, I think we need better communication too, because, mainstream offices don't know necessarily where traditional practices, what organizations are providing traditional practices. So we need to have that community connection. Thank you. And thank you for inviting me to this conversation.
Yeah, absolutely. Thank you. And a lot of great recommendations there. I'm curious, Joanne, we had started with you from the NCAPA sort of advocacy perspective. There's been a lot of great sort of policy recommendations here. I'm thinking of PATA, for example, to the recommendation of advocating for alternative medicines being covered by health insurance. I know there's actually been a long history of work to try and have greater incorporation of many of these practices and have coverage in typical healthcare plans. But how likely does that look? What happens to that advocacy in times like this, where we're facing severe cuts in general to healthcare? What's kind of the response? How can we move forward on those kinds of agendas from your vantage point?
Thanks, Sarah, for that question. I think it boils down to educating and informing these members of Congress and their staff, right? They may not be familiar with alternative treatments, and if they are, that's great. But I think it always boils down to what are some of the local impacts that we as advocates can demonstrate and point folks to, so they understand, hey, there's this form of alternative medicine, or there might be this program. Here's what the impact looks like in your, as a member of Congress, local district or state, and this is why you should care. This is why you should listen to your constituents and advocates in general. I think what we're hearing oftentimes on the Hill whenever we're engaging in advocacy is a couple things. One is, what's the return or the benefit? How are programs being impacted, and what are folks on the ground saying? So anytime that we can coordinate and organize in those ways to make sure that those local stories, for instance, are shared, is one way that we can organize.
Yeah, perfect. Thank you so much. I mean, it's just that friendly reminder that all politics is local, right? So reminding elected officials about the needs that are happening on the ground in their districts is always a key component here. I'm seeing in the Q&A section, someone had wrote in that they are a physician. They're seeing, their take on discrimination being experienced from physicians might have something to do with how questions are being asked. And I think that's absolutely right. The cultural competency, I think, piece, can often be a key component. Karthik, we just have a couple of minutes left here. I wanted to bring you back into this conversation. You, of course, have been tracking these issues for many years, many months, many years. Curious your thoughts in terms of how you're seeing some of the responses throughout this survey, maybe some changes that you've seen over time, and maybe even how it connects to some of the other policy areas that you've been tracking in the last several months or years.
Yeah, thanks, Sarah. One thing I should say it all depends on how much weight we give to ever experience discrimination in a health setting, right? Because if you look at the data, it adds up to 50% if you include rarely, right? Which means they've experienced it maybe once, maybe more than once, but it's still seen as a rare occurrence. Now, should that be zero? Yes, it should be zero. So that's one thing I think important to keep in mind in context. And Jeff, I think part of the way I would say this too is that community health, FQHCs, especially, and other community health organizations, being able to receive care in the language or someone who respects your culture and your traditions, that is one thing. That's what APTO members do. It's unlikely that but maybe they experienced discrimination in some settings and then they went to this, right? So I think this is where survey data can hit a barrier. You need to do interviews with people to figure out, okay, what happened? And did you then look for alternative providers because you just weren't happy? Or were you stuck, given your geography or given your particular insurance plan, et cetera? So I think these are the kind of things where different types of organizations that do organizing in the community to advocate is just so critical. I'll also say for me, our community is evolving and our country is changing so quickly. For me, it doesn't surprise me when I see the findings that financial stress is like the biggest thing. And I'll just say I am not someone in health or mental health. I would not have thought of that as like the biggest mental health or stress challenge in our communities. As political scientists, we're just like, oh, that's the economy. People are struggling, but you don't think of that as like a psychological burden. So that was revealing to me, right? And also just shows you with other surveys that we've done, including most recently with NCAPA, the economy dominates, and it's dominated for the last year and a half. Yes, all these other issues come up, but even when it's health, it's about the affordability of health. And let's not forget like what Congress did last year in terms of enacting policies that caused premiums to spike. And what'll happen conveniently after the midterms, when millions of people are going to be kicked off of coverage, that level of anxiety and stress is going to go through the roof. And it's not a good place to be. So that's something, it's really hard to keep our attention on any one issue because it seems like every day is a new issue. And especially with the war in the Middle East and Iran as kind of a major source of uncertainty. But healthcare, I mean, the three major drivers of costs are health, housing, and cost of everyday goods. And we've kept a focus on health today, but a major aspect of that is the affordability concern and access concern. And so that's something I think that's worth tracking. But it's unclear. I mean, you don't hear politicians talking about it too much right now, but they might talk about it more as we get closer to election day.
That's absolutely right. And I think just a really great way to kind of bring this whole conversation together, really thinking about those political consequences of not just the cost of healthcare, but also that psychological cost that clearly we're seeing amongst the AAPI community. We are just about out of time. What a fantastic conversation we have had today. Jeffrey Caballero, Crystal Canare, Pata Suyamoto, Joanne Panio, and of course, Karthik Ramakrishnan, thank you so much for joining us today, sharing with us incredible data, but also your insights from communities on the ground and all of the incredible work that each of your organizations do. A big thank you to all of our partners who make these community briefings possible. And a big thank you to all of you who have joined us today. Thank you for your engagement and participation in the briefing. Please continue to stay up to date on all of the latest findings from AAPI Data and AP-NORC on our website. And as always, feel free to reach out with any questions that you might have, and stay tuned for more data coming to you in the future. Thanks so much, everybody, and have a great day.